Good morning, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you today?
Doing well, thank you.
Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week here on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing our lone U.S. COVID statistic, the latest headlines, and a viewer-submitted question through today, May 29th. We invite you to submit any additional questions or comments below via any of our social media linked in the description or the regular YouTube comments. Starting with that abbreviated COVID statistic, average COVID deaths per day in the last reported week were 43 daily. In the same week in 2024, we saw 61 daily COVID deaths. Dr. Murphy, your reactions to those numbers?
Yeah, so these numbers are basically the same from last week. The overall number of deaths have dropped. But the important thing is that the difference between the year before is getting smaller and smaller and smaller. So it's still a 50% difference, but it's getting tighter. And so that's kind of a good sign in that the overall immunity and protection that people have in the population is reaching kind of going towards a steady state. Now, this is also the time when the rates of COVID are the lowest historically. And what we've seen in every other year since the pandemic started is that sometime around August, we see this summer bump. Not sure why we're seeing that, but we do. And so it'll be interesting to see what happens in August if these cases go up. Now, we're only following the death rate. So the bump may show up later because it takes weeks to get sick and some people die. So, but we will, if we get that summer bump again in the number of cases, we'll see.
Something to look out for in the future. But our first submitted question today, and our only submitted question today, comes from a returning viewer. Thank you very much. But they ask, will people under the age of 65 be able to get a COVID vaccine with these new recommendations?
Well, anybody can go buy a vaccine, but to get it paid for by your insurance or to pay for by a government plan or whatever plan, one of the 1,600 plans we have in the United States, right now, if you're 65 and older, you get it, you're eligible. But if you're below 65, but a 12 or above, you have to have one underlying medical condition. Now, in the past, they haven't really required documentation or anything like that. And it's a very, very broad definition of underlying condition. So, hypertension, any kind of even neurologic illness or any kind of even psychiatric illnesses, everything is in that basket. So it includes really a lot of people. But if you really have no underlying condition and you're between 12 and 65, you're not going to fit this now, even if you want the vaccine. And then further, the Secretary of the Health and Human Services has said healthy children and pregnant women are no longer part of the recommendation. This is a huge mistake. Many 1,300 kids have died from COVID. And when you look at those kids, many of them, a significant portion, have no underlying medical diseases. And now it's not recommended for any kids. It apparently below 12 years of age, there seems to be some discrepancy there, whether a kid with an immune compromised condition would be eligible. I would hope that they would still be. So that's the issue with kids. And the same thing with pregnant women. So pregnant women have a like natural decrease in their immunity. It helps them keep the pregnancy. But it puts them at risk for other diseases, including COVID. We talked about this in the last few weeks. There's many studies out there saying the vaccines are safe, number one. And number two, the unvaccinated women, pregnant women, have a much worse time with COVID, including miscarriages, including hospitalization, including death. And now these women, it specifies that an otherwise healthy pregnant woman is not eligible to get the vaccine. This is absurd. I mean, this is making America sick again. This is a disaster here. And you've got quotes from some of the big experts in the country, Dr. Stephen Fleischman, who's president of the American College of Obstetrics and Gynecologists. The science has not changed. It is very clear that COVID infection during pregnancy can be catastrophic and lead to major disability, and it can cause devastating consequences for families. I mean, that's a direct quote. And there's plenty of data out there that shows that the vaccines are safe in pregnancy, plus the antibodies that the mother has, she passes those on to the babies. So the young babies who are very at risk, they're going to get protected by those mothers' antibodies too. So there's a couple reasons to do this vaccination, but this is just a very bad.
Yeah, just to underscore what you were saying there, during the height of the COVID pandemic, COVID caused a 50-year high in the deaths of women during pregnancy or shortly after childbirth. This is no laughing matter in any sense. It's very, very serious.
Besides killing between 1.1 and 1.2 million people in the United States and worldwide, many more, these pregnant women had their highest level of fatalities in 50 years. I mean, this is very serious. And the people that are making these recommendations obviously have very limited, if any, medical background. They're not reading the literature. They don't believe in science.
Yeah, it's just very, very disappointing and scary news to see. But about those vaccines, Moderna has confirmed which strain they will be targeting. Can you tell us about that strain and what we should be looking for in this upcoming COVID season?
Well, this is actually a very interesting story because the currently circulating virus is LP.8.1. And that's what's mostly in the population, but a new one is coming and is going to take over LP.8.1, and that's LP.8.1.81. It's already rising. It's very high in Southeast Asia. And there's some very disturbing information from Hong Kong that this new variant has resulted in increased emergency room visits and illnesses in that area. So and hospitalizations, emergency room visits and hospitalizations. So we're not quite sure yet, but why is this happening? Is this a more severe variant? Probably. In the United States, we haven't been able to see it yet because we're not at very high levels. But I mean, that's a healthy debate to have. I would think that probably it might be best to target NB1.81 because that's probably going to take over by the time the fall season, respiratory season starts. But that is really another debate. And this remains to be seen. Is this really a more severe disease? Remember Delta that came several years ago? Delta was a more severe disease. And then we got these Omicron variants took over and they were milder. So let's see, I guess we're gonna have to just see what happens. But they're gonna target the old one. That's 8.1. Yeah, so anyway, we'll see.
Yes, we will wait and see on that. But in terms of COVID treatment for acute infection, there was just a massive literature review done on remdesivir, which we have talked about a lot on this show. Can you tell us about that literature review?
Yeah, remdesivir was the first antiviral drug that was used, that was approved for use in COVID. It's given intravenously. It's had many, many studies all done by the NIH when they were doing this kind of work. And it's always, been considered effective. And so these researchers published in Clinical Infectious Diseases, which is a very prominent medical journal about infectious diseases in the United States and the world. And this was a systematic review and what's called a meta-analysis of randomized controlled trials and real-world studies. In other words, just reports from big medical systems around the world about the impact. They looked at 122 of these studies, of which 21 were the randomized ones, where they didn't know whether they're getting placebo or not placebo. Those are the best ones. And that involved 25,000 patients and 101 real world studies with over 1.2 million people. So these are like big analyses, and there's statistical epidemiologists. If there's any left in the United States government, they should maybe consult one to review this. And they found that whether it was a randomized trial or the real world study, there was a significant survival benefit among patients who got remdesivir. This has nothing to do with vaccines or anything like that. This is just sick people coming in the hospital. It also significantly reduced the overall time for clinical improvement, means how long the patient really needs to be in the hospital, or if they go to the ICU, it shortened that sick kind of period. They did note that 3 of these studies revealed that there was no significant benefit on time to clinical recovery. So, you're looking at 122 unique studies. 3 of them, for whatever reason, showed. But this is the way science is done. So, I'm putting my money on remdesivir if I end up in the hospital with COVID. So their final conclusion was comprehensive, systematic literature review capturing the totality of evidence showed a significant survival benefit among patients hospitalized with SARS-CoV-2, the virus that causes COVID, who received remdesivir across all disease severity levels, mild, moderate, and severe. So very, very confirming data that of what we had known. And, it includes 3 studies that didn't show any benefit. But, when you do 122 unique studies, it's not surprising that a couple of them they're not going to show the benefit for a variety of reasons.
Yes, and when you hear that number of patients that were analyzed, yes, that's a lot. But importantly, like you said, it's across all severity of infection across the globe. So very different study populations as well, almost all showing consistent results there.
Yeah, there doesn't seem to be too much controversy really anywhere on the spectrum here for treating with remdesivir when you do this. Compared to hydroxychloroquine and all these other crazy drugs out there that, don't work at all. Here we got one that does work. If you get really sick, remdesivir is the way to go.
Absolutely. Now, something with a little more controversy here in the United States is the measles outbreak. Now over 1,000 cases. Can you give us the latest update on how many cases there are and where they are?
Yeah, so there's 1,046 cases. It's going to be updated like today or tomorrow. But, over 1,000 cases in the US with 2 children who died and 1 adult, none of them vaccinated. What's happening is the Texas cases, where the bulk of the cases are, had the smallest increase. There was only 1 additional case in the last, from a week ago. We'll see tomorrow or later today of what happened in this past week. But it's slowing down in Texas, but the other states are picking up. So it's just everywhere where there's people at risk who haven't had measles in the past or they haven't had the vaccine. They're just like on fire in Iowa, Nebraska, North Dakota, Kansas, Michigan, Montana, Ohio, Pennsylvania, Virginia, and other places, and even in New Jersey. So, it's going to happen. So they're going to pick off people there that aren't immunized. And we'll see when this whole thing sort of simmers down, if it does. If people stop taking the measles vaccine, this will never go away.
Yeah, that is very important to note that 2 doses of that vaccine are 97% effective in preventing measles infection. So very important to check up on those. Of course, if you're old enough, you may not have to get one at all.
That's an interesting number. 97 is like really high in this kind of world that we live in and this kind of this disease process. Nothing in medicine is really 100%. Everyone needs to know that because every human is different. The environment is different, whatever. 97 is good percentage.
Now, our final topic today is also a contentious one, the avian flu H5N1. Unfortunately, there have been more global deaths, and there was a very, very big funding change here in the United States today regarding the avian flu. Can you break down those two stories for us?
So avian flu has been reported in about 70 people and humans here, mostly dairy workers and people that work with birds. But and only like one death that has happened. But in Asia, the reporting is not as good in these places like in Cambodia, but an 11-year-old boy has died. So that's the 4th fatal case in Cambodia. Now, Cambodia is a pretty small country compared to the United States. And they have 4 deaths, and they've reported in the past mortality rates as high as 50%. So something's going on over there, but it is the H5N1. It's the same strain as here, but they're having those deaths. So that's why we've always been so concerned about avian flu really spreading widely in the population, like being able to transmit, person to person. And it's devastating in birds. We've had to cull over 170 million birds, and over 100 herds of cattle have been infected. And then they've done studies in dairy workers and found that 7% have antibody to avian flu. So that means they had it and didn't report it. So that extrapolates out to between 9 and 10,000 people, and we're reporting 70. So we're reporting like a drop in the bucket because we're not really testing very, very well. So that's that's how this thing can spread. Then today we have hot news right off the press. The federal government canceled a $766 million contract with Moderna to develop an avian flu vaccine. We have some other vaccines. We have other avian flu vaccines ready to go. But Moderna was brought in just in case this virus changes and can transmit better. So it's it's like, it's your insurance, basically. And they did it primarily because of the mRNA technology. Now, the mRNA technology is really what saved America, saved probably another 1 million or 2 lives or so in America as the technology that got the COVID vaccine. Well, some people just, for whatever reason, don't like the mRNA technology, and they canceled the contract because of the technology. So they can find other ways to make it. They're more expensive and they're more complicated to make. It takes longer to make. The mRNA technology is like it's like the modern technology. So anyhow, and then a lot of the technologies still use eggs. So, the birds are all getting knocked off and then we don't really have enough eggs. So this is a really incredibly short-sighted decision, just to have as a backup in case this thing becomes the next pandemic. And so this is just another thing that could make America really sick again. It's very sad.
Absolutely. And just to note that because of those COVID vaccines, over 1 billion of those shots have been given out to Americans since the onset of the COVID pandemic when those vaccines were available.
Oh yeah, billions, of shots. There's so much data on this. It's amazing.
Also, if you could fill in this gap, I understand that the COVID vaccines were the first mRNA vaccines to be put out on the market and widely used, but the technology was developed over a long period of time. It didn't just sprout out of nowhere.
Over, I think, 20 years. It's not a new technology, but it finally got implemented when COVID came up. I don't know if you remember at the beginning of the COVID pandemic, nobody thought there would be a vaccine for 1 or 2 years. And because of this technology and the ability to do the sequencing of the virus so quickly, you know, from the identification in December of the first cases and documentation to the approval of the vaccine was 11 months. I mean, this is just nobody in any health department in the world in the early phases of this pandemic, of the COVID pandemic, predicted that in 2020, we would have an approved vaccine shown to be effective and safe. And it saved many, many hundreds of thousands, if not a million American lives. Already we lost 1.1, 1.2 million. And these, in some comments I've heard, oh, they were sick people that were going to die anyway. This is not this whole story. There were plenty of people with no underlying illness, disease, or anything that got sick, including children and pregnant women, but also in adults. And yes, people who are very sick and frail, it's going to be very highly lethal for them. That is true. And the same thing with the flu, but you can still get it, and you can get really sick, and you can die from these things. So, you know, we're still having 41 people a day die. So this is more lethal than the flu. It's more severe than the flu. And it's more prevalent than the flu. And we offer vaccines for everybody 6 months and older. So if this is this for the avian flu, if this thing mutates and transmits human to human, whoever did this policy is just, it's going to show that that was a huge, huge mistake and could result in some people dying.
Yeah, absolutely. Just not what we wanted to hear at all. But on that note, our time is up for today. So thank you so much, Dr. Murphy, answering our viewer submitted question, breaking down all the data for us, and keeping us informed. It's much appreciated.
Thank you, Katie. You did a great job setting all this up.
Thank you. And thank you all for joining us for this week's episode of the Ask Dr. Murphy series. We hope to see you again next week. And as always, please leave any questions and comments down in the comment section below or via any of our social media linked in the description. Have a great weekend.
Bye-bye.